All right. Hi, Dr. Mahony. I'm so glad to see you. The last time we spoke was in Rome, actually, and we were at that AAMS Congress, and we talked about your research that was just coming out. And I want to talk more about your research, but I know there's probably people listening who don't know exactly who you are and why I like talking to you so much, but you're an orthodontist. So give a little background on how did you get from being an orthodontist straightening teeth to somebody doing PhD research on sleep apnea?
Yeah. So, interesting question. When I trained in classical orthodontics, which was in the University of London, I had no exposure to early intervention treatment, number one, nothing to do with airway, but I was just lucky. We had an elective term where I could do some research, and I went to Sweden and I did research with Dr. Sten Linda Aronson, right? And he just opened my eyes, luckily early in my career, on the link between mouth breathing and poor facial growth and development. Now, what Linda Aronson had done, and I'm happy to share that paper I published with him to any of your audience, but what Linda Aronson did, he compared two cohorts of patients, those who were obstructed nasally because of large adenoids, and then those who were normal nasal breathers. And then he did something further. He took the kids who had adenoids, did adenectomy with his ear, nose, and throat team, changed their method of breathing, and then remeasured what happened 5 years later. It's landmark research, right?
Wow.
And clearly, you know, there's this, as you probably know in your field and my field, there's still so much debate that people feel that there is no correlation. And it's kind of like, I just roll my eyes and I, you know, sure, when I did this stuff 25 years ago, there wasn't that much in the data. Now, every paper I see in orthodontic journals, in ear, nose, and throat journals, in pediatric journals, is all on this topic, and that's great. But you know, there are still some doubting Thomases, right?
Yeah.
But to me, I don't want to be known as an academic, because I'm certainly not. I do research because I'm finishing my PhD. But at the end of the day, I am working in the trenches, and I see kids with these problems all the time. I see the frustration of the parents who are going from pillar to post, just being sort of not handled correctly by my medical colleagues. Like, I'm sure you've seen it. You've got a kid who is clearly obstructed because their tonsils are huge and the tonsils are touching. And I still have some ear, nose, and throat doctors who will say to the parent, what are you worried about? Those tonsils will shrink as the child gets older, or the tonsils the tonsils are not going to be removed unless I can see 5 episodes of tonsillitis a year, you know, blah, blah, blah. What they're missing is that during the time that child has improper posture, they're getting facial growth and development changes that they can never really recover from. And then you look at all the great stuff coming out of Stanford, and you look at things like a drop in IQ, you know, and parents need to know this. Parents need to be aware of what to look for in their children. So, you know, the first part of my PhD is really identifying risk factors in children. And they're common risk factors that a parent can actually, pick up. And it's the parent, it's the mum who's got to drive the deal, right? So that the second part of my PhD, which is taking ages and ages to get the data, because remember, I'm not a statistician, and so I'm relying on other people to assess the data for me. But the second part of my PhD is, okay, we identified these kids, then what? So I broke these identified sleep disordered breathing children into different treatment modalities. And no one has ever done that before, certainly not to the depth and extent we have. And that's interesting as well, because it shows that not one treatment modality gives you the perfect result. So we're talking multidisciplinary care. And yet I see so many people involved in this deal sitting on the sideline and saying, oh, no, all you need is the ear, nose, and throat. No, all you need is expansion of the maxilla. No, all you need is good oral myology. Well, the truth is you need it all, right?
You're going into all this stuff. I want to break it down because this is awesome. You're talking about it all. So the reasons that we kind of connected up was for that whole mouth breathing awareness campaign that I started, and you're talking all about that with all your research now, and how mouth breathing affects that facial growth and development. So now, I mean, you've got clearly documented research about this. You're talking about palate vault, facial growth. Kind of break that down a little bit with what are you guys seeing when you do the run the results?
Let's start with the raw data. So I looked at patients referred to me for an orthodontic opinion, right? So these patients weren't necessarily coming in because they were identified as having sleep apnea or sleep disorder breathing or mouth breathing. No, they were just malocclusions. And of course, I had to limit the age group. So I looked at 7 to 9. And that's because in my practice and the way I deal with kids, I tell my referring dentist, please don't send me them at the orthodontic age of 13, 14 because the damage is done. So, I didn't want to look at the 13, 14-year-olds because unfortunately, then, the treatment options available to them are quite drastic. And so we looked at the younger kids. And basically, I did a Bears questionnaire, which I'm sure most of you are familiar with, and it's not the only questionnaire that's available, but it's a great way to assess whether there's a risk for these patients having sleep disordered breathing. And then from that, we went one step further and we did sleep studies for these children. Now in Australia, you can't do at-home sleep studies, so it has to be hospital-based PSG. So it's very accurate data, because I've seen other papers that have really just based their data on a sleep questionnaire, which is highly subjective. I've seen other people who base their data purely on a pulse oximeter on the kid, which is accurate, but not to the degree of a PSG. So that, I think, sets my data apart. And I was lucky that I have very good respiratory physicians, pediatric trained physicians who believe in this and were willing to do a lot of these sleep studies at no cost to the parent. And because you can imagine, some of these kids had 4 sleep studies, right? They had a baseline study. They had a study post nose and throat intervention, whatever that may be. Then they had another study post my orthodontic intervention, which could have been palatal development, repositioning upper and lower jaw, what we call dentofacial orthopedics. And then the last sleep study that we did, because every time we had to show, had there been any change? Because, why would I do orthodontics if I couldn't demonstrate an appreciable change in this kid's sleep pattern / apneic events, right? And then the last section, which I know interests you and a lot of your colleagues, was the children who then had I call it MFT, so myofunctional therapy. So for want of a better word, the kids were taught to breathe through their nose, right? Have their lips together, have their tongue on the palate. So you and me, Sarah, that's just common sense. Of course, we want that. But you'd be amazed how many high-end specialists kind of don't get that, right? And the thing is, the kids who did the best were the kids who already had the palatal development because they had room for their tongue. They could breathe through their nose because the ear, nose, and throat sorted out whatever problem they had. So they're the kids that really excelled. And there's so much data to look at. We had kids who were ADHD who went off their medication. We had bedwetting kids in the sample who stopped bedwetting. So there's, I can see all this exciting stuff, but this is where I've got all this raw data. I just need people to look at it for statistical significance. But if we go back to the first part of the study, my supervisor said, well, look, Derek, what did you see cephalometrically on the kids who came back with high apneic events from the sleep study? And Kevin Boyd. Kevin Boyd and I have chatted a lot about this. And the common thing we saw was the maxilla being retrognathic, right? The face being longer, and of course, in a lot of the kids, the mandible also being retrognathic. So what I call
too far back.
I know you're familiar with Jefferson analysis. We use that as a guideline. So it's what we call biskeletal retrusive long, right? And Kevin is the one who said, Derek, we should term this a new malocclusion and call it a malocclusion as an identifier risk factor. So we called it class 4, right? So class 3 is the big lower jaw, normally because the maxilla is too far back. Class 2 is the normally the retrognathic mandible or normal maxilla. Well, we had kids who kind of had both of the defects. And they 100% had the worst sort of sleep, right? So that was one thing.
Yeah.
And I thought that would be good enough because I thought that, but then, I've got this this professor who just said, okay, well, that's fantastic. Now why don't you measure this? And then when I measure that, he goes, why don't you measure this? And this is why this is going on and on and on.
But it's so much information. I mean, it's so much good stuff. I mean, do you see this as something that will transform the way we look at sleep disordered breathing in our patients? I mean, I feel like it will, but do you see this as like kind of game changing for the data that's out there? And now you're bringing in so much more data. Something I wanted to ask you actually was, we kind of think that about 1% to 4% of kids have sleep apnea or sleep disordered breathing. And your information says it's a lot higher, right? I mean, what numbers are you seeing?
So here's the problem. Most of the studies, and if I can give a plug to my Facebook group, it's called Dr. Mahony's PhD, because I put all these papers, because I've read over 500 papers on this topic, right?
That's so
and
much.
what I'm trying to do is put those papers into subheadings, right? So which papers looked at hyoid bone as a predictor, which papers looked at palatal vault, et cetera, right? But the main thing that we wanted to discuss is that was there a cephalometric predictor for these kids? Now, all the studies you're quoting, 1 to 3%, and I know
that's
which
what
ones. They're looking only at obstructive sleep apnea. Do you see what I'm trying to say? And yes, OSA is the dangerous one, but it's the smaller minority. So if you limit your study on anything to OSA, your data is going to be low. We looked at the bigger picture, and the correct term is sleep disordered breathing syndrome, right? That includes OSA as one category. It includes upper airway resistance as another. It includes mouth breathing. It includes primary snoring, obstructive hyperventilative syndrome. So as a result, when you look at all of those, which you can only do a proper sleep study, then you find more. And look, to me, I haven't done a study looking at the general population. So my study was based on kids who had malocclusions. And I can tell you, 9 out of 10 who had a severe malocclusion had sleep disordered breathing. So I think you've got to get the terminology right.
Exactly.
If you only, I think if I sublimit those kids who actually have sleep apnea, let me just talk a little bit about the sleep study, okay? So the traditional way of measuring sleep was just the number of apneas and hypopneas, right? That's where the term OSA comes from. Now, that misses the kid who doesn't have an apneic event but has labored breathing because he's got a deviated septum or he's got massive adenoids, and he snores and he's got daytime somnolence and he's hyperactive at school and blah, blah, blah. Yeah. But he has a perfect sleep study. This is what I'm trying to say, right?
Yeah. I know.
If you look at the kid, and the kid, that kid who's kind of constantly fidgety, he's not sleeping well. Mum knows he's not sleeping well. But the thing is...
But it's not showing up,
Exactly, yeah. So I think...
I have a question on that. When you're doing the measurements, and obviously you must be accounting the RDI. I think that's what you're talking about, that respiratory disturbance index. So I hear that one apneic event is sleep apnea in kids. Like, that's bad. We need to treat that. So when you're looking at RDI, I mean, what range do you see in that?
Same. And unless it's zero, it is identified as a problem.
Okay.
Yeah, exactly.
That's, that's pretty common.
You asked me about my career. So after I got into this, I was hooked. I went off and did a degree in dental sleep medicine, right? I had to, so I could learn sleep, I met amazing people. I realized there's a high correlation between these kids and GERD, right? Sleep, GERD is silent reflux.
People don't talk about that enough either.
Yeah. And as dentists, we see we see wear on the teeth and we just assume it's bruxism, but many times it's actually gastric reflux, right? And then I started looking at, because we measured that in the sleep study.
Oh,
and then,
I was going to ask you that, if you guys measured.
And guess what the most common cause of GERD is? It's constipation. So then you have this kid and you ask the right questions and mum says, oh my God, how did you know he was constipated? How do you know he grinds his teeth at night? I said, well, because we've looked outside the box. So you know, and I thank my sleep physicians who taught me all this, and I've taught them dental stuff. I mean, these guys are highly intelligent, but they wouldn't know a malocclusion if it hit them in their head, right?
Oh my gosh. It's so funny that you're talking about constipation, because I just made a post on that saying, you know, mouth breathing may cause constipation, and of course there's lots of reasons for digestive issues, but just that smooth muscle activity that comes from the mouth breathing versus the nose breathing, and it's all you know, coming together, and I didn't realize the GERD connection. So that's super interesting, and I'd love to see your research on that too.
And of course, so that kid may not have an apneic event, but the GERD is disrupting his sleep. Do you see what I'm trying to say?
And causing more inflammation, right?
Correct. Right.
So now
it's got a whole bigger topic, that I'm not just looking at faces and the facial changes of the kids. I'm not just looking at changes in their arch width and their palatal vault. I'm actually looking at their sleep, right? So our goal at all costs is to get that kid back to the events of zero. So that means that they are sleeping well. And if they're sleeping well, there's so many things that happen. The correct growth hormones are released for them.
It's huge.
It's huge. I mean, you deal with parents all the time. How many of these parents have that kid who's not sleeping well?
A lot,
right? And they may just go to a sleep study that doesn't measure bruxism, that doesn't measure airway resistance, and only measures apnea. And then they're told, well, your kid doesn't have sleep apnea, right? And then they say, well, okay, well then now where? Right.
Well, so clinically, when you see these parents coming in, what is the conversation that you have? I mean, are you telling them, it's different when you're doing research, but let's put that aside. Like, a mom's there, the kid has all these symptoms. Do you say, let's do the orthodontic treatment, you need to go to the ENT, you need to see the myofunctional therapist, or how does that conversation go?
Yeah, so what I say is I first of all, I identify that as part of my orthodontic record, we had a sleep study. I then explain to the mum that the sleep studies come back that your child has blah, blah, blah. And to the mum, it's a big relief, right? Because she said that explains a lot of things, etc. And then I say, before I start my orthodontics, which is why you came to me, right? I actually think we should now get a nose and throat evaluation, right? Okay. And they're on board. Why? Because the sleep study has shown something, right? Otherwise, they're probably going to be resistant and say, well, listen, Dr. Mahoney, I've come to you because I want my kid's teeth straight.
Yeah, I want straight teeth.
And now you're sending me to this other specialist, and, you know, what are you talking? But now they're willing to go to see the nose and throat doctor because we've identified the problem, right?
Yeah.
And then, of course, when the kid comes back, and they've had, say, their adenoids removed, adenoids and tonsils, or their turbinates reduced, then the next thing I need to do is change their jaw structure, not just straighten their teeth. And that's what I'm quite good at, I feel, because I know the right appliances to work with that develop the palate while I change the tongue position. Right now, you know what I've learned along the way. Listen to people like Dr. Zaghi. I've finally figured out why some of these kids who have maybe no upper airway problems still have a narrow palate. There's so many of these kids that are tongue-tied.
I know.
And don't ask me, you know. In the past, I thought I was leading edge because I identified the anterior tongue tie.
Yeah.
You know what I'm saying?
Yeah.
Zaghi has taught me, and you know.
Me
Dr.
too.
Zaghi.
Yeah, I know. I work with him a lot.
He has taught me how to look at the back of the tongue and look at what happened. Because at the end of the day, if a kid can get the tip of the tongue up to where it needs to go, that's only half the problem.
Yeah, they have to get the
base
back
of the tongue.
Yeah.
So I just, you know, it's kind of exciting for me, but unfortunately, when all my nose and throat doctors did their evaluation, as part of the study, we made them check for tongue tie, right? And I was
they're not looking at that type of tongue tie.
I know. So here I'm looking at Kotlow's classification.
Yeah.
Then Audrey Yoon comes along and says, well, actually, in fact, what's more accurate is the motion measurement. And then Zagi comes along and says, yeah, that's good for anterior tongue tie. What about posterior?
Yeah.
I mean, where will this end? And I'm going, oh my God, I was just about to publish on the number of kids who are tongue tied. But anyway, that's good. It's all good.
It's all exciting. I mean, I feel like I haven't been doing this for anywhere near as long as you, like getting into this field. And I feel like I've seen so many changes in 10 years, or I'm only 9 years really. But it's gone from, like, in my field, talking about tongue thrusts to talking about facial growth and like sleep and all these important, like, big health concerns. So I mean, I think that's really exciting. And now
you know what? I don't know about your side of the world, but you know what's going gangbusters in Australia? It's this thing called mewing. Have you seen that?
Oh my gosh, yeah. Well, it's because of Mike Mew and his YouTube channel. Oh gosh, I know.
But what it is, the public, look, rightly or wrongly, I mean, I may or may not agree on the age at which mewing will work, but really, isn't mewing just what you're teaching? It's
pretty much. I mean, it is. Yeah.
Lips together, breathe through your nose, right?
Yeah, now, that's all it is.
Look, thanks social media, but wouldn't it be good if parents realised that mewing is a way when the kid's young, right, of influencing? I mean, how many parents don't want a good-looking kid? Right?
I know. And the good looking comes with the good health, you know, like you're going to look good if your jaws go correctly. And then because of that, you're going to have a good airway and good tongue space, and you're going to be healthy and good looking together. So,
and I mean, I see, we've got to be careful ethically of me saying to a parent, oh yeah, come and see me, come and see Dr. Mahony. I mean, remember, Sarah, you worked for me, I don't know, 20 years ago, but you remember when I graduated, the first thing I did when I set up my practice, this is 30 years ago, I used the term full face orthodontics.
Yeah, you're so forward-thinking.
So I think the wheel has gone round. But I can't say to a parent, hey, come and see me because I'm going to make your kid more beautiful than the guy down the road. I don't even
say that. I leave that out.
But what I can say is, hey, your kid's not doing well at school. Your kid's not sleeping well. Did you know that there's a link between their jaw structure and this? Did you know about? And that's where I come in. You know? But what the exciting thing is, if you follow so the second part of the study now, after we measured everything on these kids, is what treatment did we did and how did it influence the original measurements we did, okay? And definitely I can tell you uncategorically, even before the stats come in, right, that the best performing, the ideal results where the kids got back to zero were the kids that had ear, nose and throat, orthopedics, myofunctional therapy, in that order. Right?
Good.
And it kind of makes sense because, you know, myofunctional therapy is not going to work as well in the kid who's nasally obstructed, right? Myofunctional therapy is not going to work well in the kid whose palate's like that.
Yeah.
Fix the nose and you fix the palate, then the myofunctional therapy is going to work, right?
Yeah.
But even said that, I have subcategories where the kids did ear, nose and throat, did orthopedics, but then dropped off because they just couldn't be bothered to go back and do all the myofunctional, right? And I compared that group to the group who did the myofunctional, and a huge change, you see?
So the sleep results were better when they stuck with the therapy and they did everything else. That's good.
Correct. Right.
Yeah.
And I saw relapse in some of my expansion in the kids who weren't doing the myofunctional exercise. So again, why don't we think of myofunctional therapy as not just a way of improving the sleep, not just a way of promoting forward growth of the face, but also a way of retaining what we did orthodontically. Does that make sense?
So important, yeah. I mean, I see this every day, and I know that the therapists that I work with and the doctors that refer to me and understand this stuff, we know that. But I would like it to get to be like a mainstream idea, you know, like that would be really good.
No. And I mean, I lecture, as you know, around the world, and I love it when at any age. I had a dentist the other day. He's 65, Sarah, and he said, Derek, I'm about to retire, but then I heard you on YouTube, and I thought this is really interesting. So he came along to one of my lectures, and he was just amazed at the simple things like, the tongue needs to be on the palate. Yeah, of course.
I know.
And I'm thinking, wow, but look, give him credit. He's 65.
Exactly.
He's seen the problem. He's realised he was never taught it, and he wants to do something about it. So he's come back into the practice he sold on a part-time basis, and guess what he's doing? He's looking at kids and helping them with the stuff that I think, and it's fantastic. And of course, all his patients love him. But all his life, he said, Derek, you know, all I ever did was drill and fill, and I did a bit of simple orthodontics. I think he learned straight wire techniques. So, you know, he used to get the 14-year-old and tidy up their teeth. And meanwhile, he realizes now he was missing all this other stuff. So look, what I'm excited about my PhD research is, you know, it's involving oral health therapist / hygienist / speech pathologist in the OMT side of things. It's involving obviously dentists and orthodontists in the thing. It's involving my medical colleagues in sleep, my medical colleagues in nose and throat. So it's really good. And I mean, you've got to take your hat off to people like Mark Moeller, who has set up that multidisciplinary academy.
He's really working hard doing that. Yeah.
And
it's a lot of work.
It's good. It's a lot of work, but it means that people are talking to each other and they're sharing data, and it's all for the benefit of our patients, you know.
Yeah,
so that's what I.
For sure. No, and I'm happy because I get to meet people like you, and you know, you're on the forefront of a lot of this stuff, and I think it's exciting that dentistry and medicine and health, it's changing so fast. So it's
and you know, let's go back to when I was in dental school. We had no real link of what we were doing in the mouth had any benefit systemically. You know, now I think we realize that dentists are like gatekeepers of the airway. I feel they really are, because you know, when I say dentists, I mean dental health professionals, right?
Yeah.
Because we are looking in the mouth probably longer with better lighting than most of our medical colleagues. So we can pick up things, right? You know, we can pick up the tongue ties.
And people come in more often.
Yeah. And, you know, we can start measuring palatal vault. And another part of my study, you know, I thought this is great. I've identified hyoid bone as one of the predictors. I've identified class 4. And then my supervisor says, okay, now what about all those digital models you did? Let's start measuring the width of those. So I said, oh, my God, really? So we did. And
so what was it about the hyoid bone? What did you measure? Like the distance to the mandible, or like what was the
so there's two measurements we did. We did hyoid bone position when it came to mandibular plane, right? So tip of eye to mandibular plane. And of course the kids who had the worst apneic problems / sort of breathing, the hyoid bone was downward and backward, right? Compared to normal. Now that, of course, I think anatomically makes sense because there's more chance of their tongue obstructing their airway. So that was one factor. The other thing we looked at was the position of the hyoid relative to the second cervical vertebrae, right? That also, right? But, you know, when I started having to, and every time my professor gets really excited and said, oh, look, you've got all that data, go and measure that, I have to read another 20, 30 papers, right?
Oh, gosh.
And that's why I want to share these papers, because to me, I'd never heard of hyoid bone position. And then when I read some classical papers, and a lot of them come from Brazil, you know, and a lot of them are published in Portuguese in pediatric journals. And so, you know, luckily I have this. Yeah, luckily I have this amazing PA who is able to find these papers for me, right? And then I'm putting every one of these papers I read up on the Facebook group and saying, hey, this has actually been documented back in 1930, right?
That's the amazing thing. Yeah, and you were talking about Kevin Boyd. I mean, he digs up these crazy like journals from the 1920s, and they're talking about palate width and expansion, and it's so fascinating.
Did he show you that paper from Dental Cosmos? It was like, I think it was 1905, and it was already talking about how dentists should collaborate with ear, nose, and throat doctors.
Yes, I think I saw that one.
And how the teachers will identify this as a lazy child because of, oh my God, this is, wow.
All the same stuff,
Yeah. And remember like Al Fonda, bless his soul, used to talk about the oral physician. And I think people ask me, what do I do? I used to say, look, I'm an orthodontist. And all of a sudden the discussion talks about, well, that incisor of mine is crooked. You know, I'd like to say, look, want to say that I'm an oral physician. I look at kids' overall health. I'm a craniofacial biologist.
Pretty much.
I'm that more than I am an orthodontist.
Well, I agree with all that. And I don't think people know, like, you're pretty into anthropology and stuff too, right?
Yeah.
I mean, you've studied skulls, you've looked at this stuff. I'd love to hear your theory, if you have one, on why are our jaws changing so faster. I mean, we know the soft food and breathing issues, but what about tongue ties? You know, I don't know why so many people are having tongue ties. I don't know if you have any insight.
That's a really good question. I haven't got the right answer to that, but you know, there are those in our profession who feel that primitive man, maybe because of his mastication or whatever else, had natural release of these problems. That's one theory, right?
Oh, okay. I hadn't heard that.
Right.
The tongue tie would release on its own through chewing hard foods and.
Exactly. Right.
Okay.
That's one theory I've seen. The problem is when you look at skulls, there's no soft tissue.
Yeah, you can't see where the thing was or the tongue.
Exactly. But however, when Kevin's looked at more skulls than I have, right? Because he's doing his PhD in anthropology. But I think if you look at primitive man, and you look at the work of Weston Price and the work of Corricini, what they showed is three common factors. Breastfeeding in primitive tribes was a lot longer because they didn't have access to bottled formula, they didn't have access to pacifiers, etc. So the babies were properly breastfed for a long period of time, number one. Number two, they ate off the land. So, you know, they were eating very healthy, they had to chew, you know, blah,
like
blah,
tough
blah.
meat, tough roots and stuff,
But if you measure the size of teeth, not the skull, but the size of teeth from our primitive ancestors to today, the size of teeth hasn't changed, right? So think about it. You've got the same number of teeth, the same size of teeth, but in a jaw that is definitely smaller.
Much smaller.
Okay. So what are the two great professions if you want to understand the research? Well, to me, orthodontics, because there's going to be crowding as a result of that. And two, periodontal disease, because it's harder for people to clean, right? But having said that, I mean, one thing, I'm a big devotee of Dr. John Mew. He's been given a hard time, you know, by his colleagues because he was the first one to come up with his, what he calls his tropic premise, that postural changes cause malocclusion, right? Now, when you think about it, I think he's hit the nail on the head because he's compared, again, a lot of Bjork and Skeeler's stuff, and he's looked at, you know, the maxilla growing downward and backward, causing the long face compared to a good-looking kid where the maxilla grows forward. And, you know, so yeah, like I can probably answer your question with a question, what causes a malocclusion, right? Now, remember, I went to a really top-notch university in the UK, and the very first lecture was on, you know, why do people have crooked teeth? And I remember distinctly, it was genetics.
I hear that
Dad
a lot.
Dad has big teeth, Mum has a small jaw. Johnny's going to get crowding, you know. And look, I'm not dismissing there's some genetic deal with class 3. There's genetic disposition of affected canine. There is. But I think there's a lot more environmental factors, right? The way you chew, the way you breathe through your nose, are you tongue-tied, you know, et cetera, et cetera. So, you know, I would love to be able, and I do this in my lecturing, but I'm lecturing mainly to professionals. I'd love to be able to lecture to the general public or write a book one day for the general public.
We're kind of trying, you know, we're doing YouTube videos. We're getting information out, so that's kind of doing it.
But my topic would be true interceptive orthodontic care. Now, to me, if you ask an orthodontist what's interceptive, they're going to talk about an appliance, they're going to talk about... But to me, what is true interceptive treatment? Educating a mother-to-be about the importance of breastfeeding, educating a mother-to-be to go and get their kid's tongue properly evaluated by someone like Zagi early, and then getting that little kid from day one to swallow correctly, breathe through their nose, and bang. I don't think honestly, I think that will be the death of my profession. You will not see malocclusions, right? So how's that for a bit of a radical process, you know?
It is radical, but it's so ironic that that's actually not radical, you know? But it really is. I mean, in our modern
you know,
world.
Sarah, many dentists sort of the golden days of dentistry were pre-fluoride days, wasn't there? When there wasn't fluoride in the water, every second kid had a mouthful of cavities, right? So I think in dentistry we've got on top of that deal, right?
Yeah.
But what we haven't really come to is how can a dentist educate parents on nutrition? You know, have you interviewed Stephen Lin? Stephen Lin has done some great stuff on that, right?
He's doing good stuff.
I mean, I see it all the time. You get these young kids who are on a pacifier who then have sloppy food. And nowadays in Australia, for mums on the go, everything is processed and the kid doesn't even need to chew the stuff.
They don't, everything's like in a little pouch. So, I mean, what do you think the future holds? I mean, do you think it's helping that, the ADA just came out with that statement saying every dentist needs to be screening for sleep disordered breathing? Do you see that happening in Australia too? I mean, have similar things been kind of changing on a bigger scale like that?
I see it certainly amongst my students. I can't really give you statistics for the general population, but we do follow the Americans quite closely. So that American Dental Association white paper was great. And now the AAO, they've been very progressive. They have a white paper on the orthodontist role in screening. And so it's very good. It's very good. So look, I don't think there needs to be factions and people fighting over what's right. Or I mean, you still will get. And what frustrates me is the people who say, "Oh, that's all rubbish," and oh my God, you know, I won't quote names, but I think you know who I'm talking about. You know, who is the nail in the coffin of progress? Who says, "No, that can't happen. That can't happen." And yet they have no solutions of what can happen. Do you know what I mean? I don't like those people. But anyone who's kind of trying to contribute and try to do the best for their kids, I'm all for that because at the end of the day, I want all my patients to end up with good sleep patterns, with good-looking faces, with less need for major orthodontics. You know, the way nature wanted it to be. So that's really, you know, my goal, my intention. And I know, Sarah, you've done a great job. A, educating the public, but B, I have so many young students of oral myology here. They do a number of courses. So in Australia, there's 3 or 4 ways of learning MFT, right? Yeah. And some are from the dental, some are from the speech path mold, you know, et cetera, et cetera. But the problem is, then these people graduate, and unless they come and work in my clinic where they're seeing, you know, 40 kids a day, they don't get the practical exposure and they get a bit lost and they think, oh my God, you know, blah, blah, blah. So I know you do a great job with your online tutorials, and I've had 2 of my co-workers who've, what is it? You have a mentoring program, right? I don't know exactly what you do, but they say, oh, it's really good because if I have a tough case, I share it with Sarah and blah blah blah. So so good on you. You're getting that side of the thing sorted out. That's fantastic.
Yeah, I'm trying. I mean, there's a lot of people who come into the field of myofunctional therapy or oral facial myology, whichever you call it. It's the same thing. Yeah. But they're really passionate and really excited, but they don't necessarily know how to get started or what to do, and that's really where I feel like I can offer that guidance, and I can say, let's make this a real world. Let's actually do it and not just talk about it. Let's do it and help patients and find the orthodontist like you and, you know, just try to help people. So that's what I'm trying to do from the professional side as well as the patient side, which is like you. I mean, I know you've got that orthodontic mini residency, and you take a lot of dentists and orthodontists through that program, and I think it's such a good resource too. So.
Well, you know, I think when you are so excited by what you see, you want to share your knowledge. You know, you don't want to just keep it to yourself, right?
And you want to help other professionals be successful. Yes. You know, that's how I feel. So. Yeah. And I mean, I can give you a whole list of people I'd like you to interview. You know, Jim Papadopoulos is the respiratory physician who did most of the sleep studies for me. He's the one who really taught me about GERD and taught me about constipation and all. You know, he's a guy. You know, you've already interviewed Zagi and. I haven't. No, I should ask him. I'm going to be seeing him at the end of the month.
You know, I've seen him lectures many times, and it was only just recently actually sat down and had dinner with him for the first time. He's such a lovely, humble guy, and he knows He knows so much. And he just, like when you're doing your sleep residency at Stanford, everyone like grabs certain parts of the pie. And he said one day he had this kid who they were about to do T's and A's on, and the sleep god CJ came in and said, "Oh no, I want you to look at this."
CJ, I haven't heard it, Christian Gila.
Yeah. I can't do my French accent, but
Yeah.
he said, "Oh, this is not important. You must look at the tongue. The tongue is the future of sleep." So all of a sudden, Zagi, okay, this guy's so powerful. Zagi said, "Right, I'm going to do my research on the tongue and blah blah blah." So, but geez, I mean, Zagi. How I think it should be compulsory for every dentist to learn about tongue position and airway. Mm-hmm. I think it's compulsory for every ear, nose, and throat doctor before they graduate to listen to Zagi.
Yeah, for sure.
They have no clue in their training of how to properly assess a tongue tie. And if they do, they just laser the anterior tongue tie. They don't even then promote oral myology post their surgery. They just assume in typical surgeon fashion, if I
cut it and it'll just change.
Look, Sarah, we teach our kids how to talk, right? We teach our kids how to walk. We've got to teach our kids how to breathe through the nose after 9 years of being nasally obstructed, right? We've got to teach our kids how to use their tongue after 9 years of being posteriorly tongue-tied,
For sure.
It's just, and that's where you people come in, because, in a busy orthodontic office, we are doing blah, 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 but we need that constant reinforcement for the parent to say, well, listen, we've released the problem, but you've got to now change the habit. You've got to change that ongoing habit. And, we have little stickers for all our kids that we give them where we say, put it on your PlayStation when you get home, put it on the fridge, put it on your school bag. So every time it reminds you, is your mouth closed? Yeah. Is your tongue in the right position? Are you breathing through your nose? And, have you seen, Marissa Santos, the lady from Argentina?
No, I'm not familiar with her.
She has this amazing resource. Yeah, interview her. And she, you've heard of Dr. Khan. She's that orthodontist in California. She developed that face bow.
The bow,
which I'm using now because it brings the maxilla forward without any detriment on the mandible.
Yeah, I think it goes off the chest, right?
Exactly.
Yeah, it's really smart.
So her colleague of mine in Melbourne, Simon Wong, and Marissa Santos have come up with this program called GoPex, right? And what they do is they just get a parent to video their kid eating, sitting down at the table doing their homework, and oh my God, it's amazing. You see this really bad posture, and then they coach them over a 30-day period, and I'm looking at some of these before and after photos and videos. In 30 days, you can do a big change. Parents don't get it.
It's pretty amazing. With a little dedication. And I think although it's a paradigm shift to do a therapy or a GoPex program or something like that, it's so important. And I think, the people that I see that are really successful, they want to make changes. They want to be healthy. They want their kids to be healthy. And I think, it really can work. So I have high hopes that, in the future, this will just be more normal. Like, oh, your kid needs myofunctional therapy, just like, oh, your kid needs braces. Or maybe even in the most idealistic situation, we would just start with the breastfeeding and the stuff that you talked about and just avoid all that later. That would be the best.
Look, there's so much to do, and it's exciting to, and I'm hoping, I know everyone asks me, when is this PhD going to be finally ratified? I have my initial defense in June this year, and I'm hoping by the end of the year, that's my goal. I've actually cancelled 6 overseas lecture trips I've been invited to speak at, because I realize every time I'm out of the country, out of the office, my PhD goes on the back burner. But I've actually employed a couple of really smart, switched on uni grads who understand the stats. I've got all the data, but it's just a case of giving it someone.
Dissecting it up. So
exactly.
Well, I guess, I appreciate your time. I guess we can wrap it up. So maybe you can just finish with one word, just to go back to that mouth breathing awareness. One little takeaway about mouth breathing. What would your advice be to people about mouth breathing?
Well, I think number one, mouth breathing is not normal, right? How does that sound?
That's perfect. I'll quote you.
Because like there's some parents who say to me, yeah, but my whole family mouth breathes, and I say, and then sometimes if I'm having a bad day in the office, I can't help myself to say, do you think it'd be normal if your kids started eating through their nose, right? And then the parent goes, oh yeah, okay, right?
Yeah,
but,
totally.
So let me end by saying mouth breathing is not normal. There you go.
Perfect. Thank you. Well,
okay.
Let's wrap it up then. I thank you so much for doing this, and I guess enjoy the rest of your weekend, and we'll be talking soon.
Great. Thanks, Sarah. Thanks for all you do, and we'll catch up. Bye.
Thank you.